Still there, Rich?
I am still here.
We've
All right.
had
You
an
guys see my
exciting week.
screen?
Rich just got back. I just got back, and let's do this.
All
It's
right,
8
let's get
o'clock.
started.
I can see your screen good.
All right. Thank you guys for joining us during the week. Hope everybody's off to a good week. I know the Spurs are playing tonight too, so I want to get through this. Somebody can give me an update on the score there if you want to sneak away to the TV after a little bit. But let's go ahead and get started here. So I'm the bald guy on the right there, and I'm fortunate enough to be partnered up with Guy. We've been at this for well over a decade, each of us, and we made several thousand devices between us. So we've teamed up with Keller. You've been using them for a long time to make your devices, haven't you, Guy?
As long as I can remember, and we really appreciate their support, and they're helping us put this on tonight.
Yeah, thank you guys for joining us again. We're I think you had the first one of these ever made, didn't you, Guy? These Clear Dreams that came off the.
I wore it last night, and I wear it almost every night. So it's one of the my favorite dorsal designs. And this is about bruxism, and we're going to talk a lot about other devices, but we're also going to talk about snoring and dental sleep devices for airway problems, and this is one of my favorites.
Yeah, and you guys, I know a lot of you dentists out there are having these devices made through Keller, both the TAPs and EMAs and dorsals, as well as the NTIs and the Plus and all of this stuff. So our disclaimer at Dental Sleep Solutions, we're the most trusted, innovative, and customer-focused provider of solutions in dental sleep medicine, period. We love to say that because nobody else out there does what we do. We're not just a software company. We do all the facets of putting together a program to help your office do sleep in a better way. Anything you want to add to that, Guy?
I think you said it all. We have everyone muted. I'll mention what I was getting ready to say is that we have quite a few attendees this evening. So if we unmute people, it'll be a little unruly. So if you have questions, type them in, and we will try to get to them either during the presentation or after. And we're going to get going on this. We'll show a blow up of this slide at the end. We do a lot of hands-on courses for dental sleep implementations. You can see them listed. Maybe hard to read on your screen there. We'll show a blow up of that at the end if you're interested and have you time to look at that.
Yeah, so let's get started. We're going to talk about bruxism, how you define it, how many people out there have it, why we think some people grind their teeth. And I think as most of us already know, we know the consequences of what happens when we do that. And we'll talk about different ways to manage that specifically as it relates to sleep. So that's kind of your overview there. And we're not really going to talk so much about the relationship that bruxism has to temporomandibular dysfunction. We cannot separate these things completely, but we are going to talk mostly about sleep and the ramifications of the airway and bruxism. So when we get into craniofacial pain and TM dysfunction and TM disorders, that's a very complicated thing. I know we could talk about this for 2 days, and at the end of 2 days, we probably none of us would agree on everything. So we put this slide up there to show you all that we know that this is a sophisticated subject. We're going to make it as simple as we can, but we're also going to concentrate more on the aspect of sleep. And you've got some history with this, don't you, Guy?
Yeah, I mean, what I want to talk about just for a brief moment is I've gone through a lot of education running my restorative practice. I went to school at UK. We had a great instructor, Dr. Occlusal there, who a lot of you have read his book. He's still one of the leaders in TMD and bruxism. I moved to Florida. I had there I am getting ready to go to clinic, and I think there's a slide of me graduating in there too, even. But when I moved down here to Florida, I had the pleasure of working with Pete Dawson and doing a lot of his courses, which is right across the bay, all about occlusion and a lot of things that are still very valuable as a restorative dentist to all of you all practicing out there. And then I went to the Pankey Institute. Just got back about an hour ago from there, as a matter of fact. I just drove back across the state, learned tons about occlusion and so forth. And through all this, and learned some things from Frank Spear. I think it's a picture of him coming up too. And all these people are masters of teeth, but we still had these people who bruxed and we didn't know why, and none of them really had the answers for me. And then as I started getting involved in sleep, I started reading from the gurus of sleep, and this book here at the bottom, this Craig Roth, Dement's the father of sleep, some people call. And as you start looking at the gurus of sleep and what they say people brux their teeth at night, they say it's related to these things called microarousals. And if you look at the literature in dentistry, and the next slide I'll talk about, some of the experts in that area, Levine, as far as what do we say? And when we start looking at it, nocturnal bruxism, we're not sure that occlusion has a whole lot to do with it, and it plays a minor role, if any, in the grinding the teeth at night. It may be part of this microarousal or this autonomic sleep arousal response, which is the same thing. And just wanted you to start thinking about that. And I want to thank my partner for doing most of this presentation or researching it. He spent hours in the weekends and researching bruxism. I think he's one of the country's experts now of all the research he's been doing over the last year. So I'll be uncharacteristically quiet throughout some of this as I learn a little bit from my partner as well. So what do you time of what's that?
That is uncharacteristic.
I know, so.
It's hard to get a word in, most of the time around Guy, but that's because he knows so much. He knows a lot about this too. And share just for a second, though, Guy. I mean, remember when you were telling me that story about you done a complete reconstruction on this guy, upper and lower, roundhouse, everything, and they were still grinding their teeth, and I remember you saying, somebody said, hey, there's still an interference, right?
Yeah, well, one of those people on that screen there told me, and I still had them in temporaries because I was smart enough to do that, and they kept saying, well, you've got to have a posterior interference. You've got to have a posterior interference. That's why they're jutting their jaw forward and grinding their teeth at night. And, man, I wanted to grab one of those astute individuals you just saw on the screens before by the head and just come over here and you find it. And, something that's occurred to me now is, why would we grind our teeth down to the nubs at night when we're asleep? Well, if something else is more important in the hierarchy of the human body, like breathing, it makes all the sense in the world. So don't leave this webinar saying we think all bruxism has to do with sleep. I think you're going to see a lot from Rich here that is counter to that. But a lot of it does have to do as a sleep. And as a matter of fact, if you look at the sleep physicians, so the book we talked about there, they classify bruxism at night, grinding of the teeth, as a sleep disorder. And so we've been going to dentists to learn about a sleep disorder. Maybe we can learn a few things from these sleep experts that a lot of you aren't as aware of. And that's pretty much a lot of what I have to say tonight. And let's move on with some of the other studies and so forth.
Yeah, well, that's very well put, and I love your story about that guy because, I remember you telling me, man, I'll give you $10,000, you can come over here and find an interference on this guy. So, we do get to the point though where we get frustrated with some of this stuff, and we have to, we kind of go back to, where we started and what we learned. That's what we all kind of do, and that's why I have this in here, this paradigm shift, that we talk about. So, I'm a big Malcolm Gladwell fan and read a lot of his books, but, patients come in and we see this. We see these abfractions and we see that kind of stuff. If we're in a restorative course, we're talking about fixing teeth. Well, what's going on here? We see these teeth that are kind of ground down like that, and what in the world is making people do this? We see these large mandibular tori, and don't you just want to reach in there and just cut those things off, Guy? And kind of like that mole on the guy in Austin Powers, right? But we see all that kind of stuff. That's what we observe, right? And we know as dentists, they break things. We put things in their mouth, they break it, and their jaw clicks, pops, and their muscles hurt, and they got headaches and toothaches, and their jaws lock up and they can't move, right?
And the crowns we just did broke off, and then we got to explain why that happened. As a restorative dentist, that's one of our big frustrations, and I hope that we start thinking about this. Maybe some of these things will make a little more sense, and we can help prevent some of those problems, the innate challenges of being a restorative dentist.
Yeah, so we assume they're grinding or they're clenching or something like that. And what do we, most dentists just make a night guard, right? Uh, but we'll go through a little bit of this stuff. You know, again, we could talk about this all day, but you know, like Guy said, equilibration doesn't have much to do with this anymore. I do think it does occasionally. You can have interferences. You can have some issues that people have to deal with. So you always got to use your brain, but you know, let's start talking about some of this stuff and what this shift is, and that
May I say something on that
sure.
slide before, Rich? I will say this, and Rich hasn't done restorative dentistry in a little while, and I'm a little bit more close to it. I do believe equilibrating and having good occlusion is still important, at least in as much as that we won't break teeth. If things hit evenly, we may not get as much sore muscles if one side hits before the other. So all the stuff I learned from those masters that it was still very important, and a lot of it still is very applicable, because if we have good occlusion, our teeth will hold up longer, and we will prevent some problems. But the interference, I don't think, is what's actually causing a lot of the problems like we once thought.
Right, and there are, thank you for clarifying that, Guy, and there are no absolutes in any of this stuff, you know, as we talk about this. And, you know, some people need combinations of all of these types of things, you know, as we do this. But one, you know, several points along the way we want to make here, but one certainly is that this is not necessarily a linear relationship. You know, somebody who really has severe wear, we look in there and we go, my gosh, they must really be grinding their teeth at night. That's not necessarily true. There are several studies out there that looked at this, and there isn't necessarily a relationship to somebody who has severe wear and whether or not they are presently bruxing their teeth at night, right? And some people can brux their teeth down to nothing, and nothing ever hurts. They don't have any other issues. And other people seems like they just clench a little bit, and they do. So that's part of this paradigm shift, you know, as we look at this. So here's Gordon Christensen did this, and there's just one. This is an N of one, right? But we got a college kid who's wearing his teeth down, and somebody made him a full occlusal maxillary splint. He was wearing it routinely, and then let's look at this guy now. We're going to do a couple of different sleep studies, right? We're going to do a baseline, then we're going to do one with a splint, and then we're going to do a couple of tests with him with the a mandibular repositioning device in there. And we'll kind of summarize this through here. Guy, you're very familiar with this too, aren't you?
Yeah, and you all may not know what AHI is. AHI is the number of times someone may have an airway obstruction per hour. And if you look at the baseline of that, and we compare also the bruxism, we can see 4.7 on the baseline, but we gave them a flat plane splint, and at least for this one night they went up, and so did the bruxism. And then after they went ahead and made the mandibular repositioning device, the number of times that we had an airway restriction went from 4.7 down and to 1.6, and the bruxism index went down as well. So what's the bottom line on that study? It's just one, but and we don't want to say, well, goodness, you can do one thing of anything, just to get you thinking that there are times where we might not be making the most appropriate choice for any one patient. I think that's one of the reasons, you know, just this one patient can demonstrate that it can be different on anybody, and we got to start thinking about our patients and maybe using our brains like Rich likes to say, and thinking outside the box a little bit on occasion. What happened here is that the patient with the flat plane occlusal guard, it made the bruxism worse, it made his sleep apnea worse in this one particular case.
Yeah, and is that always the case? No, not necessarily, right? But again, we're making this, you know, we're tend to make people flat plane occlusal splints. I know a lot of you guys are using NTIs, and we're big fans of NTIs and do that. But the point is, you know, don't keep doing the same thing over and over again and expect a different result. So other studies, when we look at this, you know, that only had an N of one. So there are a lot of studies out there. Some made the bruxism better, some were worse, some didn't have a change. You know, what if we use a mandibular repositioning device? So again, we're talking about a patient who is bruxing their teeth at night, and we're going to make them a splint, a flat plane occlusal splint, and most of the time it makes their bruxism worse. Okay, occasionally it makes it better, and sometimes it doesn't seem to make much of a difference. But there are a couple other studies out there. Here's one with 12 patients and reduced the number of sleep bruxism events, and the protrusive position was not noted. And a second study with 28 patients improved significantly both the sleep bruxism and the scores. And here's a third one again, right? So the point we want to make in this is that there is more than one way to skin a cat, so to speak, and NTIs, we'll talk about them quite a bit as we go through this and look at this, but we want to make you guys aware that, and we've seen this for years, haven't we, Guy? Back before we even knew what we were doing, we were making mandibular repositioning devices, and a lot of the TM dysfunction just went away, didn't it? We didn't know why.
Yeah, I was worried at first when I first got involved in making mandibular repositioning devices for our apneic patients. They may have a little discomfort, a little popping or clicking, and what's going to happen? And my gosh, a lot of times they improved, and that's still true. And we know a little bit more now. I think you implied that we know everything. You said back when we didn't know what we were doing. I think we still have a lot to learn when it comes to this subject. So we're still learning, but we know a lot more than we used to. And some things are starting to make some sense to me. It's kind of the aha moments are starting to trickle in when it comes to our patients and kind of the TMD bruxism challenges that we have.
And as I started learning about this, Guy, you know, I go to the library and I pull up these things and you look at all these articles, and I started writing a lot of these questions out. You know, why do people grind their teeth in the first place? Is there a difference between somebody who does it a day and a night, and how many people have that? You know, how long do they grind or clench? And we talked about, is current tooth wear indicative of present grinding? No, it isn't. Are there specific events that precipitate or surround tooth grinding? There are, in fact, and again, we could talk about this for a couple of days, you know, and I have studies that support every single one of these things as we talk about this and do this. We're not going to show them all to you tonight. If we don't have something that we can support with a study, we will tell you it's anecdotal and this is our experience, because we're learning more about these things as we go along, and there's more and more studies being done that specifically relate to a lot of these questions. We'll talk a little bit tonight, and we'll give you a couple of drugs that are being used out there to treat bruxism and the effect that they have on it, and it does appear to be related to specific sleep stages. So again, what do you think about that first question there, Guy? Do people grind their teeth, usually snore, or have sleep apnea?
Well, back to my training in sleep from that Krieger slide, people who grind their teeth have 3 times the likelihood of having apnea, according to the sleep gurus. So yes, I don't know if usually, I certainly say they more often than the general population have an airway problem, according to the sleep gurus. Do they usually have do people who snore have sleep apnea and usually grind their teeth? I mean, I think yes on that one too, but not quite, quite as strong of yes in my book. What do you say about that?
No, I agree. I agree completely. And there's a study that I remember Jason sent that to us the other day. Hasn't even been published yet. They just looked at, a bunch of people who were severe grinders, and they gave them sleep studies, and like 80% of the people had that. So I haven't read that study. It's going to be published here in the next couple of months, and we'll give you an update on that when we get to it. But we do know that a flat plane occlusal splint can make sleep apnea worse. It doesn't always, but it can. We do know that it occasionally helps decrease the number of sleep bruxism events, but sometimes it makes that worse as well. The mandibular repositioning devices tend to decrease both of those things more consistently. So again, a lot of these are just good questions, and if you're looking for something to do, right, 5 years ago there were 2,500 papers on bruxism. So there's a full-time job, somebody out there reading all this stuff, and we've got some good studies in here. As you look at this stuff and you do it, we want to try to get your arms around all of this stuff. So again, part of that paradigm shift, what we observe and what we do, is not necessarily what we should be doing or what we learned, even from very smart people who were dealing with this the best way that they knew how. But when we look at just occlusal factors, again, we want to show you some studies out there, and there's just not much support for equilibrating or rehabilitating somebody's entire mouth or putting them in ortho and doing that kind of stuff. Again, like Guy said, you got to use your brain. You got to be smart about this stuff. So I don't think I want to go out there and say never do you have to do that. But the point, again, we want to try to make is that there's a much more of a relationship to the airway and what's going on up in the brain than there is something locally. So as we define this, let's look at a couple of different groups who do this. The prosthodontists, the sleep docs, the craniofacial kind of guys, and then if we can get a consensus. So the prosthodontics talk about this as a parafunction, right? It's just a habit. We have this rhythmic or spasmodic non-functional, right? So they're not chewing, gnashing, grinding, or clenching, which may lead to occlusal trauma. They don't have anything in there about the joint, okay? And the rhythmic side of that is Michael Jackson. The spasmodic side is Steve Martin. Right? Remember when he was sitting in the parking lot going, I think I got it. So,
I was wondering what those slides meant. I just saw them a while ago, so great. I get it now.
And what about the sleep docs?
So rhythmic and spasmodic, I'll remember.
So what do the sleep docs say? They bring in sleep to it, right? It was sleep arousal, right? I mean, when you got a hammer, a lot of, whatever. Micro arousals, right? We talked about this kind of stuff and the sleep arousal. So it's a parafunction again. When we look at that, and then we go to the craniofacial pain people, right? And they're the first people that put in the diurnal or nocturnal, right? Including clenching, bracing, gnashing, and grinding of the teeth. So I think the consensus here is that it's just a repetitive muscle activity characterized by clenching or grinding, or bracing or thrusting, and it can happen during the day or it can happen at night. Okay, so what's normal? Okay, so about once an hour seems to be normal, but if you do it more than once an hour, then we say you have sleep bruxism. So how do we measure that? What do? We put EMGs on people and we put them to sleep, right? And then we measure it. How many times are they doing it? And then we get into we'll talk a little bit more tonight about the different types of things and stuff like that. But again, we want to reiterate again that this is a movement disorder that is more centrally mediated as we do this. So,
hey, Rich, is there? Yeah. I think there's another movement disorder called periodic limb movement disorder. Is that correct? Where the legs or maybe the arms might twitch at night. It's the same classification. Bruxism falls into that same, according to the sleep doctors.
Right.
That's what we're considering now. And my question is, do we? I think the difference is we don't send people to the orthopedic surgeon who twitch their legs at night, because they're not hurting anything. And I think what the problem here is, if it does have something to do with sleep, what they're hurting is the teeth, which is kind of our problem to take care of. So we're kind of cleaning up the mess afterwards. And I think that's where some of the confusion comes in, at least with the nocturnal bruxism. I think we're going to talk a little bit about daytime bruxism, which might be somewhat different.
Yeah, but what's causing this? I mean, is it obviously it's multifactorial. When we look at central issues or brain-mediated type things, or is it a pathophysiological entity in and of itself, right? Are there other things that go on in our when we look at schizophrenics, for example, and even at bipolar disorder and things like that, there are differences in how these people manifest bruxism, or is it more of a peripheral thing? And I think the answer is it's all of the above, and in any particular patient, it may be a little more heavily weighted on one of those than the other. But the classification, as we look at this, is that the patient is aware and that they have masseter hypertrophy for sleep bruxism anyway. So that's how I evaluate this in the clinic, Guy. When somebody sits down and their teeth look like they're worn down pretty good, well, at one point I know he's been grinding his teeth, but clench your teeth together as hard as you can and just reach over and feel their masseters. And some people, it's like, holy cow, man, it's world-class masseters. And if the guy he clenches his teeth for about 2 seconds and then he starts to go into this quiver shake, and oh my gosh, that hurts, well, we need to be careful about jumping right in and making that guy a mandibular repositioning device if he's got some muscle splinting going on like that. But patients are aware of it. There's tooth wear and there's muscle or joint discomfort and masseter hypertrophy. And when we think about why people clench, I think it's all of those things, as we do this. And we have to be smart about what we do. And we're going to talk about that, as we go along. So clenching and grinding and how they do that and why they do it are all very good questions. And when we think about clenching, we think more about just kind of clenching your jaw together, and the grinding is more of a noise. I love that video you have, Guy, of the guy grinding his teeth at night, and it's like the fingernails on the chalkboard,
Yeah.
isn't it?
Yeah, it's really frightening if you think about, wow, that could be my patient that I just did some veneers on or something. It could be quite scary.
Yeah, but it's related to all of these things. Is it related to stress? I'd have to say it probably is, or sleep, or the airway, or brain chemistry. The more we learn about the brain and brain chemistry, the more I am just amazed at how much we don't know, right? All of the above, none of the above, who knows, right? I think we just have to be smart about how we do this and what we do, and we have to use our brain, like you said. So let's start to separate this right now, Guy, between the awake and the sleep, right?
I think that's a good idea. I think how we're going to treat them is going to be different too. Awake bruxism and sleep bruxism.
And that's our acronyms that we'll use for tonight, okay? Awake bruxism and sleep bruxism, as we do this. So when we look at awake bruxism, right, for the most part, we see this in younger females. I can't tell you, I'm on the Humana TRICARE list, and I get so many of these young females that are daughters of military people, and they come in and they're just in tears, with their pain, because they're just so much pain, in their joint. Look at that. So again, we're going to spend a little bit of time here talking about awake bruxism and sleep bruxism. So we do see with sleep more airway issues, right? Obviously, because you don't have that as much when you're doing that. Sleep staging issues. And we also think that it's much more centrally mediated than it is peripheral. But as we put these slides together and we do this, we did not get rid of the peripheral factors. That can be the interference and the other things that Guy was talking about with all of this stuff. But when we look at awake bruxism and sleep bruxism, it makes a difference in how we treat these people, right? Some more good questions. I have like 6 pages of these questions as we do this, and we look at this, and again, we have to be smart about how we do this, okay? And we do that. So the point is, we can't ignore either one, can we, Guy? Awake bruxism or sleep bruxism.
Yeah, and we can't assume either one either. So just because there's wear on the teeth I think what I'm starting to learn is we have to start asking questions and trying to be a little bit of a detective and determine a little bit more about where this wear has come from. Is it currently happening? And is it causing any problems that we need to address?
And why do we need to address it? You know, because there are consequences, right? This is how we started this thing in the beginning, right? From destroying teeth to destroying crowns to, I mean, my gosh, even dentures, right? And jaws and headaches and
Yeah, and destroying marriages you even have on here. So I mean, this is important stuff here, and I think destruction of dental prosthesis, dental work that you do. I can say this was one of the more frustrating things in dentistry, and if we can find a way to minimize that and to see, well, geez, if this person is at risk to brush their teeth at night, or this person's at risk to brush during the day, and how are we going to manage that? You know, I don't say we alleviate it in a lot of cases, but we need to be able to manage it. If we had that little Bruxism crystal ball, we could sell it for a bunch of money, couldn't we?
oh yeah.
Yeah.
And I'd love to talk about sympathetic tone too, because I think, you know, when we think about sleep apnea and sleep disordered breathing, you know, your airway's closing down, and we think, you know, what happens a lot of times that this process that we see is we see this increase in the cortical activation in the brain, and you know, that is related with an increase in both respiration rate and heart rate before the muscles actually contract. And then, of course, you get this sympathoadrenal activation. You get that squirt of adrenaline that opens your airway as well. So I think sympathetic tone is a big deal in all of this, and we certainly don't want to downplay that. But I think that's one of the big connecting points that connects bruxism and sleep disordered breathing. So a couple of different studies here, you know, when we look at this and we talk about how many people have it. Here's 1,000 patients that we just did a questionnaire, and then we gave them a PSG and we put EMGs on their masters, right? And then we look at how many people have it and what type of frequency of events they have and stuff like that. So here we see a positive association between sleep bruxism and insomnia and a higher degree of schooling. So that's a big study, you know, 1,000 patients. Here's a couple more studies where they look at specifically the difference between awake and sleep, and the prevalence of this in the population at large, you know, both from kids, because I know those of you who still work on kids, right, out there in the dental office, we used to get that question a lot, Guy. You know, my gosh, you know, what do I do about my kid, you know, grinding his teeth at night? Well, you take him to an ENT and get their tonsils and adenoids taken out. That's what you do. You know, that's the short answer. But I think in general, when we think about this, I like simple ways to remember this. And awake bruxism is about 20% of the population. We see it again more with females. It can be associated with tics, like a neurologic tic, something like that. Every study that I looked at said it was related to stress. And when we talked about stress, it talked about familial responsibility. And do you think there's a lot of that going on with these baby boomers now, Guy?
Oh, gosh.
How many of us are putting moms and dads into homes, right? You got any experience with that?
Right. Yeah, yes, we do, as a matter of fact. And, you know, I think when you say that stress, the slide you had a couple before talking about the adrenal and, you know, all that chemistry that I maybe don't remember, but is that cortisol? That's basically the stress hormone, right, that you were talking about? So I'm trying to learn as I go along here, but yeah, I think that's what that was saying, isn't it, on a chemical level?
Yeah, that's certainly part of it, which has blood pressure issues and everything else, right? So, you know, interestingly, 3 or 4 of the studies were, you know, just referenced the fact that these familial responsibilities really played a big part in a lot of this kind of stuff. So even though we see it more in younger females, you certainly can see this in any part of the population. So I always think about awake as about 20% and sleep is about 10%. Okay, that's just how I remember it. Those are simple things. We see it a little bit more in kids as adults. We see it a little bit less, and in the elderly, we see it even less. So again, that's kind of gives you an idea of how many people out there have it. There does seem to be some crossover. About 20% of these patients can have both. Okay. And that's important to understand because, again, if we just see the effects of bruxism on their teeth and in muscle splinting and things like that, we don't want to assume that it's awake or sleep. I think we have to put our thinking caps on. We have to ask some questions and have to try to figure it out. And a lot of this stuff is just information that we get from the sleep textbooks and the sleep side of things. Again, we see these events very much related to sleep staging. They almost always occur in non-REM stage 2 sleep, occasionally stage 1, and they almost always peak right before REM sleep. And I just find that interesting. The more I learn about sleep staging and this kind of thing and all of this stuff that relates to sleep staging and memory consolidation and our dreaming and a lot of this kind of stuff. But again, 20% awake bruxism, about 10% sleep bruxism, and then there is some overlap. And when we look at how we measure this, okay, we're going to put some EMG leads on the masseters. There are other muscles involved when people grit their teeth together and clench and grind, but for the most part, it's just the masseter. And when we look at this and we talk about these phasic or rhythmic, right? You remember that Michael Jackson was the rhythmic one, right? We get this kind of real quick burst. It's just kind of a zzz, zzz, and then you separate them by that. And then we have the tonic and sustain. That's for more than 2 seconds. And then, of course, you can combine these two. And most of these are combined in some sort. So this is just researchers looking for a way to quantify some of this stuff and what they're doing. And together we call these things the rhythmic masticatory muscle activity. We call these the RMMAs, and that's basically what we're measuring is how many times people are doing this. And we talked about this. Normal is about once per hour. Anything more than that, we start to talk about someone who has sleep bruxism as we do this. So there are a lot of problems with this. We don't have enough information yet to make really well-informed decisions about this because we can't even decide on a definition for what it is, right?
Yes.
The studies, when you look at them, that we're measuring different things. We're measuring different muscles, different one person. Think about in the early days of sleep. You just had the pleasure of spending some time with Dr. Rimmers, didn't you, Guy?
Yes, I did for a couple of days. Yes, you'll be seeing him in a few weeks.
Stories. Yeah, I'll be seeing him in a couple of weeks at our San Antonio meeting on May 15th. But don't you love hearing his stories, Guy, about how they were just figuring this stuff out in the beginning?
Yeah. He's got some good stories about making CPAPs out of Hoover vacuum cleaners, and very entertaining. And it really puts things in perspective. Here I'm talking to someone who's been doing this a while, and yeah, we've learned a lot. And he'll be the first to tell you we've learned a lot, but we certainly don't know everything. And I think we're not going to define the answer for you tonight, but hopefully we can help you understand better ways to manage your patients, because that's really what matters. I think is if we're going to treat our patients, help them with their symptoms, or if they don't have symptoms but maybe they have some occlusal decay and we're going to restore their mouths, well, we want that to hold up, don't we? We don't want to put things in and then they destroy them, and then we have this uncomfortable dilemmas with our patients. So that's what we hope to at least get some of the answers to how to do that. And how to think about our patients who at least demonstrate that somewhere throughout their life that they've done something to bring their teeth together. If they have bruxism signs and symptoms today, does that mean they always have it, Rich? Does that mean we can always assume they're doing that today? I think you're going to talk about that in a little bit, aren't you?
Yeah, we are. For the most part, once somebody's a severe bruxer, they're kind of always a severe bruxer. But again, part of the problems are some people just grind their teeth down to nothing, and their jaw never hurts. They never have any muscle issues. They don't do it. So again, we're still learning about this. There's the slide you were thinking of, Guy, right? Not much variability over time. Okay, so when you look at this stuff, and excuse me, Gilles Levine, that guy probably knows more than anybody in the world put together, about bruxism and all of that kind of stuff. So if you're just going to read one guy, he's the guy you want to look up and out there when you look at this. But you will notice that a lot of this bruxism stuff is showing up in sleep journals, not in dental journals. There is a fair bit of bruxism in the sleep journals, but it seems to more be related to temporomandibular dysfunction and that type of stuff. So again, this goes back to all of this stuff, and we kind of try to get our arms around this. And we can't forget either that there are other things that are linked to sleep bruxism and that certainly exacerbate it, right? We talked about the type A personalities, the high stress, the familial responsibilities. Now, although that was more of an awake bruxism thing, you can certainly see that there. Alcoholics, caffeine, smoking, snoring, sleep apnea, these all are related and exacerbate this kind of thing. And I think it's something that you simply need to ask about as you're talking to a patient and you're consulting with a patient. Sometimes this all happens, Guy, when you're doing a hygiene check, right?
Right.
And you walk in there to check their teeth, and they're kind of rubbing their jaws. What's going on, man? Your jaw hurting? Oh, it's just kind of hard to keep my jaw open, get my teeth cleaned. You start this conversation one of 1,000 different ways. And well, how are you sleeping? We'll talk about this whole thing, and we always try to relate it to sleep because that's what I do now, right? That's the hammer I got in my hand. When you walk in, you look like a nail, right? So.
Yeah. But sometimes we want to start with the symptoms. So if they come in and they don't have symptoms, we'll show in a little while maybe the path you go. But sometimes people come in with acute discomfort, especially if it's muscle. If we just get it to where their back teeth aren't touching for a bit, if it's at night, we make them a nighttime device. The NTI is my favorite for that, to where it will decrease the muscle strength at which we can clench our teeth together when we don't hit on our back teeth, and that can calm things down, and then we can take a breath and try to analyze things a little bit more as far as the airway go and other factors that may be playing into this.
Yeah, but you certainly got to pay attention to their pain, right? If they're
Absolutely.
talking about that. And we are not in any way recommending that you don't. That's like the guy walking in, with the little chip on his front tooth. Can you fix this? Well, what about that big hole in the back with the pus oozing out? No, that doesn't bother me anymore, right? But there are other ways besides occlusal intervention and NTIs and things like that. Here's a study that when we talk about splints and we do this, I like to the analogy I like to use, Guy, is the early studies that were done on mandibular repositioning devices for patients who had sleep disordered breathing. Do you know that for 10 years nobody made a notation even or talked about how far they moved the patient's jaw forward? Does that make a difference?
Yes.
Yeah, it makes a big difference, right? So we're a little bit past that, and when we think about treating bruxism, but again, so many of these studies don't always talk about what type of device they use or what they do, and we've got to think about this stuff. So the NTI, when we look at that, that's probably the only thing, if we back that up, right? The only study only had an N of 10 decreased bruxism in all patients was the NTI. So when we look at sleep bruxism and you're making somebody an NTI, you're going to treat that issue the majority of the time. I do think you still have to use your brain. You have to think about other things as you do that. A couple of other things, with the biofeedback, I think it's important to mention this stuff because if we don't know it's a problem, then we don't know what to do about fixing it. But as we become more aware of that problem, when we make the patient more aware of the problem and teach him to take a deep breath and relax and that type of thing, this certainly works more with wake bruxism than it does sleep bruxism. But we get that. I'll even throw in, guys, something like, tell me a little bit about your bedtime routine, in a consultation. Well, when I get done checking my emails, I pretty much brush my teeth and do that. Well, wait a minute, back up a minute. What are you doing checking your emails at 11:30 at night? Or when I look at my, schedule for tomorrow? I mean, when did you learn to quit doing that?
Are you talking about me again?
So a lot of this stuff is linked together.
And back it up for just a second. One thing I think it's this fits in perfectly. And when you're talking about daytime bruxism, which you were just previously, we want to. You can get people to decrease this habit. And in the past, I've always told people to get a timer and set it for every 15 minutes rather. And when it goes off, or my teeth together, if they are, relax them. And just this weekend, I learned what I think sounds like a better idea. Someone that brought it when I was at the seminar at the Pank Institute all weekend. If you put like a little orange dot or something just out of your peripheral view, like while you're working at your desk, if you're in front of a computer or something all day, and when you turn, you see that signal, sticky note on the wall, something, and when you see that, you go, where are my teeth? Am I clenching? And if you are, then relax. And I think that's a really good idea that I heard this weekend, and then the people that who've utilized that say that they've had some decent success with daytime bruxism, trying to manage the patients and to get them to decrease that.
I like that. That's good.
Yeah, learned that just a couple days ago.
Yeah. So a couple of drugs out there, clonazepam, clonidine, and tendaspirone. These are all basically anxiolytics or antidepressants or sympatholytics, and they do show some positive effect at decreasing bruxism. I think we're a long ways away from just simply prescribing a pill to do this, but again, this sympathetic tone, this type A personality, this very stressful, a lot of that kind of stuff. I think this is what that treats more than anything.
Yeah, notice here though it makes the AHI, and again, for those of you who don't know, that's how much we're compromising our airway at night. So it's basically making the apnea or the airway worse because it's relaxing those muscles. So be careful with these type of medications if the patients have airway problems.
All right, good point. Okay, we're getting to the end here, guys. So thank you guys so much for being a great audience. Nobody's talked bad about us all night, Guy, so far, and as long as we keep them muted, right? So
yes, that works out.
That works well. So let's start at the top here and just kind of work our way down. As we think about someone who presents with bruxism, it's either something that we see or that they have some type of symptom or something like that, and we have to think about now, put our thinking caps on and ask some questions and look at some things and do this. Is this more of an awake thing or a sleep thing? And then what's the next question we would ask, which may be really how somebody presents, right, Guy?
Absolutely. So, yeah, are they symptomatic or not? So let's take the sleep side for a moment. If the patient has said, that we don't think they're bruxing during the day, I observe them too. Are they clenching while they're talking to me? And if we're convinced it's more of a sleeping problem, if it's asymptomatic, then we certainly might want to make something anyway to protect their teeth if they're showing wear, and we believe they're clenching at night. Maybe their partner says they hear them. And we're convinced it's a nighttime thing. If they're asymptomatic, we're not in any urgency to do this. We should screen them and see if we think they're at risk for an airway problem. And that's done with your screeners and your questionnaires and some of the things we've covered in in previous webinars. And then if they are at risk, which I tell you, I bet you a lot of them will be, then we need to do a sleep test. If they show that they have sleep disordered breathing, which is what SDB stands for, then let's make them an advancement device, a mandibular repositioning device, or MAD, whatever you want to call it, because now we can help the protect the teeth, help the bruxism, and help their airway. So that makes sense. If the test came out negative, we don't have them highlighted in the other direction, then we might want to make them an NTI or a bite guard such as a crystal clear or something like that to protect our dentistry and their teeth at night. So that's if they're not symptomatic. What happens if they're symptomatic? Well, I think Rich has said this over and over again, and this is what we're trying to accomplish here, is to manage our patients. We need to get them out of discomfort, and there's really usually not a better way of doing that than deprogramming those muscles by getting something between their front teeth and getting them an NTI to calm them down. Once we get the symptoms under control, then we should screen them again, and if they're at risk, we do the test, and then we manage them from there. Only difference might be if they do have sleep disordered breathing, and we do decide to make them a mandibular repositioning device, we may want to do one that has a deprogrammer built in, and we can do the clear dream with a deprogrammer in the front, or we can do a tap device where it's kind of like a mandibular advancement device with the deprogrammer. Again, if they don't, then we can stick with the NTI, or we can make them more of a full coverage, like a clear dream. So
yeah, we could go through 100 of these scenarios, couldn't we, guys? So you got to use your brain. The point I want to make here, that was good job there, Guy, is if they're symptomatic, get them out of pain.
Right.
Make them an NTI if that's what you think is right. If you're more sophisticated and you think it's a disc thing and you want to put them in a pivotal device, that's okay too. Go with this to the knowledge level that you have as you do this, but do that in conjunction with screening them. Remember, screening only takes 3 minutes.
Yep.
Are you sleepy and tired during the day? We give them an Epworth sleepiness scale. We do the AASM, the Academy of Sleep Medicine, questions. Does anybody see you quit breathing at night? Do you have any of these other comorbidities? And as you do more and more of this, you pretty much walk into a bar now and pick out most of the people that have sleep apnea. But again, go ahead and get them out of pain and then get them sleep tested. Right. What if this guy, what if you, let's walk through this real quick. This guy, he's broken a couple of crowns that you've done on him. You've been telling the guy he needs a night guard for 5 years. He won't listen to you, right? You finally get this guy, he comes in, his jaw's kind of locked one day or something like that. Okay, well, let's make him an NTI now. Now he's open to it, so we're going to get him a screen. Of course, he's very high, severe assessment for having sleep disordered breathing. Gets a sleep test. Let's say his AHI is 98.
Yeah, that happens.
What do you do then? Right. He quits breathing 98 times per hour for 15 seconds every single.
We're going to have to get him to see somebody who will get him a CPAP because that's the standard of care, and hopefully they can wear it. So we can help people sometimes with MRDs that can do that, but we can get them a CPAP. And you know what? We might want to make them both because if we make them a mandibular repositioning device, we open up the airway, we can get that person's pressure down, and that would be a really good candidate to do both. By the way, I see, Steve, you have a question there. We'll get to it in just a second. Is that what you would say, Rich?
That's exactly what I would say. And again, you can combine a lot of this kind of stuff. We have a great combination series lectures that we put together for combining different types of treatments, and we've got patients out there that are wearing an NTI at night with a full face mask wearing CPAP, and they're doing great. We got people in TAPs, with a tap PAP and a custom mask that we take an impression of their face, and there's just all kinds of ways you can do this. Right. On the awake side, talk about that for a second.
Yeah, and on the sleep side, we have a question. I'm just going to address it real quick. You know, if we have these people wearing NTIs at night, I was really concerned about that in my practice. I've made hundreds and hundreds of patients that wear NTIs for extended periods. As a matter of fact, my wife's been wearing one for at least 8-9 years, and we just don't see the posterior extrusion like we think. If you want the facts on that, contact Keller. They've got a lot of research. I don't remember how many thousands of cases that they can show with really no evidence to show that you get the posterior extrusion. Because I had the same concern, Steve, when I was doing those. That was the question that was submitted. So as far as the weight goes, you know, if we're convinced it's awake, we've done our screening, and you know, we try to figure out. You know, again, these people may have both, and we could go through 100 scenarios. But if they're symptomatic, wake time, then we need to make them a splint to wear during the day, and let's keep those, you know, the back teeth not hitting quite as hard. You can make a daytime NTI, which basically is the NTI without the protrusive portion of it. So if you make it on the top, it doesn't have the part sticking out for the lip, because we're not worried about the patient jutting their jaw way forward during the day. Or you can make it on the lower with just the lingual protrusion on. So just basically a stop that keeps them open, or you can make them a full splint. And Keller does a great one with their crystal clear splint. It's a beautiful material, and you can have them wear that during the day. Richie just did something on the slide presentation there. You want to hit the presentation mode again. If they're not symptomatic, then you know, you do what you want. You know, if the patient's not hurting, you might use the little dot in the corner of the eye, in the corner of the workstation that I mentioned earlier, and if they're destroying their teeth, then you got to decide. So I think that, you know, you can look at this flow and you can put a lot of different scenarios, but hopefully, you know, we gave you some information at the beginning, which I learned a lot from my partner there, and then we come down to try to manage our patients. We got some more questions we'll get to in a minute. We'll get to our summary first, and then we'll hit some of these questions.
So I think the biggest thing is just know what you're treating, right? I mean, we have patients all the time, well, you know, can I just make this guy a device for snoring? Sure you can, but does he have sleep apnea or not? You know what you're treating. Is it awake or sleep? I think you need to ask a few questions. You need to do a few things. You know, a guy I learned from, he told me to make 2 1.0 biocrills. He said you cover one red with a Sharpie, the occlusal surface, and one black. And you have the patient wear the red one for 3 days and the black one for during the day for 3 days, and the black one at night for 3 days. And it's really easy to tell if they're, you know, grinding their teeth during the day or night. So there's lots of ways, lots of ways to do that. But get people out of pain. You know, if they're having issues, figure it out and do it, and have a plan. Don't just stab at this stuff in the dark. You know, don't always make somebody a mandibular repositioning device. Sometimes they need CPAP. Don't always assume that there's a certain type of splint that will work better. You know, use your head as you do this. Consider the other habits and what drugs the patients are on, as well as their mental status. We didn't talk about that, but we do see some mental patients, whether we think we do or not. But you know, think about those other things. And as you work down through this workflow, we certainly want you to see that many of these patients, many of these patients that we have been making NTIs and occlusal guards for have sleep disordered breathing. That is the connection here, right? So we're not telling you to not treat that, but what we are telling you is that if they have the other comorbidities and the signs and symptoms of sleep disordered breathing, then by gosh, get them sleep tested, okay? And then when you get them sleep tested, lead them down the right path. And as I like to say, use your brain.
Use your brain. A couple of other questions, and we'll hit those real quick, and then we'll see if there's anything else, and a couple of housekeeping at the end. The thickness of the NTI, all you really care about is that the back teeth don't hit. So make it as thin as you can to have clearance in all directions. I'm not a fan of jacking the people open real wide. I don't think that helps. So make it as thin as you can to make sure that forward, backwards, left, right, they don't hit anywhere, and then you're good to go. Maybe a 0.5 millimeter. Anywhere in the back, just on the NTI. And what if you got a 0.5 millimeter clearance, just a minimal amount. And what is the level of the HI? I need a CPAP in addition to the MRD. Well, the standard of care is from the American Academy of Sleep Medicine says that patients who have a severe apnea should at least try a CPAP first.
Which is an AHI of 30 or higher.
Thank you. And but you know, if they can't wear a CPAP, then a dental device is indicated. How high? I mean, any patient who has severe apnea could benefit from combination therapy because it decreases the pressure at which they need to set their CPAP on. The higher it is, 90 is really high, so that jumps out at us. So you know, anybody severe can benefit, and especially the people who are maybe double severe, 60 and above. I definitely am thinking about that. The question is, if a patient's on Ambien and you take them off before a sleep test, I don't modify patients' medications. That's not my job. I'm a dentist. There's people out there who believe you do. My thing is, if they're going to be taking an Ambien every night, then we want to see what they're doing every night. And the purpose of the sleep test is to see what's happening on a normal night's sleep. So if that's what they normally do, then by all means they should keep doing that. So Rich, I think we got a couple other slides. I promised people we'd have the meetings. If you want to, we'll answer a couple more questions if they come up. But you know, we hope to help. This helped you this evening, and that's what we live to do. We want to help dentists treat their patients with bruxism, sleep disorder breathing, and if you want to be a member, it's more than just a software, more than just webinars. We basically are an implementation system, a complete resource for helping you treat sleep disorder breathing in your practice.
We actually do these kind of, you ask the expert kind of questions, and we do this every other week. So we have something like this. So
yes.
You can't get
I'm
a free
doing one
trial
tomorrow night for our members.
Yeah,
yes.
Yeah. And you know, so they're always great, and then you know, we open the mic, and it's just amazing.
It's a lot more of a study club type situation. Like tomorrow night, because we don't have quite as many people, and we'll ask you your questions. I have about 5 pre-submitted questions for tomorrow night's webinar for our members, and they're specifically answered by Dr. Drake or myself. If you want to try us out, we'll offer a free trial. Our team will tell you a little bit about our services. No obligations. We're not pushy salespeople, but we really think we can help you. So contact us if we can help. And here's the courses that we're doing. We're doing quite a bit. We're going to be busy. Most of those are implementation courses where we basically from A to Z teach you how to do this. And then Rich, we also have these 4 meetings a year that are open to people who are not members, but are free to members to our premier members for DS3. You want to talk about what you're doing there in San Antonio?
Yeah, just a couple of weeks. We've got John Rimmer's coming. He's going to talk to us, you know, talk about the matrix system, and I know they have all kinds of new stuff with that, and that's a way to titrate a dental device in the mouth. And one of the first patients in the country one of my patients who was the first in the country to have the hypoglossal nerve stimulator done on her, which is really wild, man.
Yeah.
I mean, you talk about, you know, making your tongue stick out every time you breathe in. I don't think I could do that. But you know, and we talk about the nuts and bolts, the day-to-day. Hey, this is how you do this. Somebody calls and they, you know, we're going to get a referral. How do we get these referrals? How do we do this? That's what we are, and that's what we do. So the one thing I want to add, Guy, to the A to Z is you get a dental device.
It's true.
You get a sleep test yourself, right? So even if you think you may have this disease and you look at that and you do that. So you can reach us at info@dentalsleepsolutions.com. We thank you guys very much for your time. We are only 2 minutes over, guys, so we did pretty good.
We did pretty good. I tried to answer the last question. I'll hit send on that. I typed the answer in there for you, Steve, about the monitor, and if we can help you, you can put our contact information up on there, Rich, as we end. I think, yep, there we go, info@dentalsleepsolutions.com, and that's where we have our DS3 system. And hey, that's pretty good for us to 3 minutes over. If we can help you anyway, from A to Z, as we say, talk to our team, and they can point you in the right direction for your dental sleep, bruxism, TMD implementation in your offices. Thanks for taking the time to talk to us tonight.
Thank you, guys.
listening to
Everybody
us, I
have a
guess.
good evening. Let's go see if the Spurs are winning.
Bye-bye.
All right.
All right. Good night.